Okay, welcome everyone to this webinar. Today we are excited to have three speakers who would talk about the application of fNIRs in a slightly different domain, in the clinical domain. And yeah, from a technology development point of view, we at NIRx, we try to do our best at providing solutions tailored towards those specific applications. What Dr. Anne Gallagher and her colleagues will talk about, you will see it is a bit of a specific application, and we understand the need to sort of tailor the solutions towards those. We also understand the need to support our users in their journey. And these webinars are one of those things we try to do to educate and inform our users on that. I'm a scientific consultant here. I'm Mahipal Chaudhary at our Berlin office. In the background, I'm joined by my colleagues, Amy, who does scientific marketing for us. She has a background of neuroscience. We are also joined by my colleague, Dr. Bankim Subhashchandra, and he has a PhD in neuroscience as well, and also a scientific consultant with our Berlin team. Before we go to our speakers, before I introduce our speakers, I would just like to point out a few minor details. Your mics are muted, but of course, we would love to hear from you. If you have questions on this webinar, please go to your GoToWebinar panel and type your questions there. Amy and Bankim are collecting and looking at those questions in the background. And towards the end of the webinar, we will discuss those questions. All these webinars are recorded, so if you miss a part, if you want to catch up later, you can go to our website and look at the webinars again. If you have any questions, if you happen to come up with questions after this webinar, please feel free to write to us and we'll get back to you. With that, I am very happy to introduce our speakers. I'll start with Dr. Anne Gallagher. She's a neuropsychologist, holds a Canada Research Chair in Child Neuropsychology and Brain Imaging. She's an associate professor at the Department of Psychology at the University of Montreal and a scientist at CHU Saint Justine, where she directs the Neural Developmental Optical Imaging Laboratory, or the short form of that is LIONlab. And for her research, she's using NIRs-EEG neuropsychological assessment to identify predictive brain markers of neurodevelopment outcomes in children with various clinical conditions such as epilepsy, congenital heart disease, premature birth, etc. She's a pioneer. If you haven't read her publications, I would suggest to take a look at her Google Scholar profile. She has written wonderful papers in the field of NIRs-EEG in clinical settings, notably developing pre-surgical evaluation techniques using NIRs-EEG in patients with severe epilepsy, which is now routinely used in several epilepsy clinics. Our second speaker, Phetsamone Vannasing. She has a background of electrophysiology. She joined Saint Justine University Hospital in 1993 as a scientific research coordinator. At the LIONlab, she teaches the technical aspects of various imaging techniques to students. She coordinates research, protocols, data acquisition, data analysis. She set up a state-of-the-art multimodal recording platform using EEG, NIRs, eye tracking, electrodermal systems. And her research interests include neurodevelopment from newborns until adulthood in clinical and healthy populations. Phetsamone received the Research Professionals Excellent Award in 2020 for her contribution to research, knowledge mobilization, training of new generation of researchers, or research support group from the Fonds de Research Saint-Quebec. Very impressive profile indeed. Our third speaker, Alejandra, she's a PhD candidate working with Phetsamone and Anne, and her PhD is in cognitive neuroscience and neuropsychology at University of Montreal. She received a BSc and MSc degree in psychology with a specialization in cognitive sciences and neuropsychology from University of Zurich. Her research interests include childhood neurodevelopment, neurodevelopment pathologies, epilepsy, etc. We are very, very happy. We are very, very excited. So let me start by thanking you three. I know you are very, very busy in what you do, and we really appreciate that you took out time to talk about your topics. And with that, yeah, the stage is yours.
Can you hear me now?
We hear you now, yes.
Sorry about that. Can you see my screen also?
We see your screen, yes.
Okay, good. So first, thanks a lot, Maipal, for this very kind introduction. And hello, everyone. Thanks for being here. So I'm very pleased to be here and talk about the use of fNIRS-EEG in epilepsy with my colleagues, Alejandra and Phetsamone, who are also very well introduced. I'm gonna, let me try this. Okay, good. So here's the outline for today. But first, we'd like to know a bit more about your interest and your background. So we'll first few polls to start with. So Amy, can you start the first one? Okay, so for the first one, we just want to know how well you know epilepsy. So just select one of the answers. So if you're an expert in epilepsy, if you know a lot of things about it, or just few things, or you don't know at all about epilepsy. I don't see the results, so Amy will help us with that. She will turn the results when people would answer. Will answer. Okay, so I can see that most of you know a few things about epilepsy, and some of you are experts in epilepsy, so so that's good to know. We're gonna adjust the presentation also in terms of your expertise and your interest. So the second poll will be about how well you know about NIRs. So let us know if you're, again, an expert, fNIRS user, if you know a bit about it, if you never used it but would like to use it, or if you don't know at all about fNIRs. I'm going to take some notes. Okay, so about 25%, a quarter of you are expert in fNIRs or are user. So it's about half of you, and 23% and 22%. And then 40% are no, I don't have my question anymore. So know a bit about it. And okay, so that's good. So most of you already know a bit or a lot about fNIRs. So for the third one, because we will talk about research mostly using fNIRs and EEG, so both techniques combined, we would like to know how much you know about combined fNIRS-EEG. So if you performed it before, if you are a new combined fNIRS-EEG user, if you have never used it but would like to use it, and if you're not interested in using it. Okay, so I'll write it down before it goes. Okay, so about 30% of you already use it, 30% are new user, and 42% would like to try it. So okay, so that's good. So hopefully the webinar will interest you. We're going to talk about this. So thanks for your participation in the polls. So we'll get back to the outline. So today, first, Alejandra will give you a brief theoretical background about epilepsy. So for those who are experts, it will be very basic, but for those who are not, you at least know a bit about it. I'll then present with Alejandra some fNIRs clinical research we have been doing in my lab and that have been done in other labs. And this will be followed by a technical presentation by Phetsamone showing videos of fNIRS-EEG data acquisition and discussing some practical aspects, challenges and solution in fNIRS-EEG data acquisition and analysis in patients with epilepsy. So before starting, I'll make you work again a bit. I would like to adjust a bit our presentation to your interests and objectives for today. So for each point, we'll ask you if you're interested or not. You can say yes to the 3 of them, to 1 or 2 of them. So we can adjust the length of each section if one section is much more interested by everyone. So maybe we can launch the 4th poll. So just say yes if you're interested to learn more about epilepsy, or no if you're not. Okay, so 82% are and 17 are not. Okay, so for the 5th poll, it's just say yes if you're interested to learn more about fNIRS clinical research in epilepsy. So what have been done in the past, or if you're not. Okay, and for the last one, let us know if you're interested to learn more about technical and practical aspects of fNIRS-EEG in epilepsy. So how we use it in our lab and some tricks about using it in patients or in individuals with epilepsy. Okay. So I think we're gonna just keep the presentation as it is and talk about each section as we were thinking to do it. So now that so now we're ready to start. Thank you very much for answering all the polls and for working. So now we'll switch and we will now work. So Alejandra will start with what is epilepsy. So you can go, Alejandra.
Thank you very much for the nice introduction. So let's directly start with some details about epilepsy. So first, it is important that we differentiate between an epileptic seizure and the diagnosis of epilepsy, where the first one refers to a transient state in the brain of hyperactivity or abnormal synchrony of neurons, while the International League Against Epilepsy has defined several criteria that have to be fulfilled in order to pose a diagnosis of epilepsy. So we say that someone has epilepsy if he or she has presented 2 or more unprovoked seizures that occur more than 24 hours apart, or if someone has presented 1 unprovoked seizure, but the probability of a next seizure is estimated to be higher than 60%. Or finally, if someone presents a clinical pattern or symptoms of a pattern of clinical symptoms that allow to conclude an epilepsy syndrome, then also the criteria for an epilepsy are fulfilled. It is also important to emphasize that this definition of epilepsy includes 2 cases where epilepsy can be considered as being resolved. This is the case when someone has an age-dependent epilepsy syndrome and has passed the age for that syndrome, or if someone hasn't had any epileptic seizure for 10 years, out of which during 5 years the person didn't take any anti-epileptic medication anymore. So we can now briefly look at some epidemiological data, even though it's very difficult to clearly specify the prevalence of epilepsy because it has a very heterogeneous manifestation. but overall, it is estimated that between 50 to 70 million people worldwide suffer from epilepsy. And it is also known that there's quite a difference between the prevalence in developed countries and in developing countries, where in developing countries it is assumed to be much higher. Another important aspect about epidemiology is that most of the patients receive their diagnosis during childhood and adolescence, and epilepsy is actually the most common neurologic disease in that group, in that age group, and about 1% of children are affected by epilepsy. So even though, as I said, the clinical picture of epilepsy is quite heterogeneous, but there have been several attempts to publish classification guidelines in order to clearly specify what type of epilepsy someone presents. These guidelines are published by the International League Against Epilepsy, which is really the main organization that publishes guidelines for epilepsy care. So first, we can determine what causes epilepsy. So for example, if a genetic origin is assumed or known, we would talk about a genetic epilepsy. Secondly, based on how epileptic seizures manifest themselves, we can say, we talk about a focal or generalized epilepsy, which focal refers to an epilepsy seizures that affect one hemisphere, while generalized seizures commonly affect both hemispheres. And finally, if there's a clinical pattern that allows to conclude to an epilepsy syndrome, one can classify the epilepsy under that name. So for example, someone may present a Dravet syndrome, and then everyone will understand that epileptic seizures are part of the symptomatology. We can go to the next slide. Yeah. So once epilepsy has been diagnosed, the treatment of choice is usually a pharmacotherapy with anti-epileptic drugs to eliminate or at least reduce seizure occurrence. And this treatment consists either of a single medication or a combination of several medications. And this treatment is effective in most of patients suffering from epilepsy. If, however, seizure control is not satisfying, or if it's not possible to reduce seizure occurrence satisfyingly with pharmacotherapy, there are alternative options. So, for example, the ketogenic diet, which is a very strict dietary regime, low in carbs and high in fat, that leads the body to go into a ketogenic state, which has been shown to reduce seizure occurrence. Another option is the implantation of a vagus nerve stimulation, which has an inhibitory effect on excessive brain activation and also can lead to a reduction of seizure occurrence. And finally, in certain patients, seizure onset can be localized to a specific cerebral region, and they may be candidates for a surgical removal of the epileptogenic zone in their brain. Now I will focus a bit more on the pre-surgical or on epilepsy surgery. And before proceeding toward the surgical removal of an epileptogenic zone, there is an extensive pre-surgical workup that is conducted, and the goal is really to evaluate the likelihood of success of the surgery, but also to estimate what risks are associated with the surgical procedure. So it is important to localize the epileptogenic zone and to clearly specify the pathology that leads to the epileptic seizures. And but also we usually aim to localize language and memory functions, because many patients that are candidates for epilepsy surgery have seizure onset within regions that are associated with these cognitive functions. So you would like to know if there is a risk that these functions may be, if there's a negative impact on these functions related to surgery. And also it should be known if there are other comorbidities for a patient that could affect the cognitive or the general functioning of a patient. So this is why the pre-surgical workflow usually includes many investigations. So for example, an EEG video monitoring that with a reduced dose of anti-epileptic drugs that aims to clearly characterize and localize the seizure onset. There's also an anatomical MRI that provides insight into potential structural abnormalities that could explain or cause the seizures. Then often there is also a neuropsychological evaluation that provides information on the cognitive, behavioral, and affective functioning. It allows to identify potential strengths and weaknesses in patients, to draw a baseline measure before surgery that can be compared to the level after surgery. It also contributes to the localization of the epileptogenic onset, and finally, it allows to identify potential comorbidities. Metabolic changes related to epileptic activity in the brain can usually be assessed with an ictal or interictal SPECT or PET examination. This can also contribute to clearly localize where the epileptogenic zone onset is. And finally, if the previous investigations are not yet conclusive enough, in some cases we may do an intracranial EEG assessment. This can either be done in a separate surgery prior to the surgical removal of the epileptogenic zone, or as a first step during the surgical removal, and allows to more precisely specify the limit of the tissues that should be removed. In the recent years, new neuroimaging techniques that are less invasive have been included in the pre-surgical workflow, and especially their multimodal application in combination with EEG is very interesting, because EEG remains the #1 technique to identify epileptic activity, and among others, it's fNIRs combined with EEG that plays an increasing role. So proceed to the next slide, please. So as you're probably aware, the general advantages of fNIRs are that it is non-invasive, that it allows to independently measure HBO and HBR concentration changes. That it has relatively low costs, and also that it is portable, which is illustrated in these pictures. So many groups now use fNIRs to assess cerebral activation during activities that require more spatial flexibility. And finally, fNIRs is known for its good temporal resolution. There are also some advantages that are particularly that apply particularly for the use in epilepsy patients. So one of them is the tolerance to movement, because it can be used even when the cooperation of the patient is reduced, or if a person has a minor epileptic seizure. And in that context, it's also a big advantage that we have direct access to the patient or the participant throughout the acquisition, which is specifically in patients or in children, allows parents or the caregiver to be next to the child, and also for us to be beside the child, or there's even a possibility that the child is installed on the lap of the parent, which really significantly increase the quality of the data, or allows to conduct an acquisition in cases where elsewise it would not have been possible to acquire or to complete the assessment. And well, finally, as I've said before, it's also a big advantage that we can combine fNIRs with EEG, so that we have a multimodal acquisition, because with EEG it allows us to control for the impact of epileptic discharges, to better understand altered activation pattern, but also to study the neurovascular coupling. I will now hand over to Anne. She will present some fNIRs clinical research that have been done by several groups in patients with epilepsy, notably on the use of fNIRs EEG in the pre-surgical workup.
And I think we don't hear you.
Can you hear me now?
Yes, yes.
Oh, sorry about that. I was on mute.
No problem.
So I was saying, thank you, Alejandra. And so now I'll talk about fNIRs clinical research in epilepsy. I'll really focus mostly on how we use it in the pre-surgical assessment in patients with epilepsy, because it's the more often use of fNIRs EEG in clinical in epilepsy, in clinical settings also. So for the first part, I'll talk about how we can use fNIRS-EEG to localize the epileptogenic zone. And in the second part, I will talk about how we can use it to localize the brain language areas. So this is the first case report we published on the use of fNIRS-EEG in the pre-surgical workup of a child with epilepsy to localize the epileptogenic zone. Although it was published many years ago, it was in 2008, it's still a good example of how we integrate fNIRS in the pre-surgical assessment of these patients. So for that particular case, it was a 10-year-old child with probable right frontal epilepsy. We used a neuroscan EEG device to record clinical and electrical seizures that were visible on the EEG. And we also use an ISS imaging oximeter for combined NIRs data acquisition to study the hemodynamic response associated with the epileptic activity identified on the EEG. So as you can see here, can you see my the arrow on the slide?
Yes.
Yes, we do.
Thank you. So as you can see here, this is an example of a seizure that we capture on the EEG. It's noteworthy that we ask usually patient to be seizure-free when they come at the lab, so they can have seizure, they have more chance to have seizure, and we don't wait, we wait less longer. So this is an example of a seizure, and these are the NIRS data associated with this seizure. So here we have time in second on the x-axis, and we can see changes in oxy. These are the full line are changes in oxyhemoglobin, and the dotted line here are the changes of the oxy concentration. And the red horizontal bar is the duration of the seizure, which is about 35 seconds for that seizure. So we can see that associated with the seizure, we can see an increase of oxyhemoglobin and decrease of deoxyhemoglobin in the channel here in the right frontal pole. So while we do the recording, then we have epileptologist who is marking the EEG to mark all seizure that the child had, and then we can go in the NIRS data to look at the associated hemodynamic response. In this patient, we had a lot of other non-invasive or neuroimaging data from other techniques. So this child had a SPECT, a PET, EEG fMRI, and EEG MEG that were able to capture epileptic activity. And as you can see, all the techniques identify the epileptogenic focus in the right frontal pole. So all the data were very concordant to localize the epileptogenic zone. So this patient didn't have any intracranial investigation, and he underwent surgery right away. The patient recovered very well from his surgery and is still seizure-free many years afterward. Actually, is doing very good now. He's a young adult and he's studying engineering. So this patient is a nice story, but it's also a great example on the importance of gathering multimodal data from various techniques to reduce the need, or at least the extent of invasive investigation to localize the epileptogenic zone. So there is less risk of infection or complication related to the surgery. Since that case report, many studies have shown the utility of fNIRS-EEG in groups of patients to localize focal epilepsy, including temporal lobe seizures, frontal lobe seizures, which are the most common type of epilepsy, but also posterior seizures, as shown in this study. This is an example of a right frontal lobe patient with right frontal lobe epilepsy. So again, this is time in seconds, and he had two seizures back to back, shown here with the I don't know if you see it well, with the horizontal black lines. So we can see that the hemodynamic response associated with the first seizure and then to the second seizure. So using the EEG and NIRS, it's possible to identify seizure and also to localize them on the scalp and into the brain. So Let me switch. Okay, so for those who are not familiar with epilepsy, I just want to make a distinction between ictal and interictal activity, because we have been using these terms. So when we talk about ictal activity on EEG, we really talk about epileptic seizure. And when we talk about interictal activity, it's more subtle activity on the EEG. So it can be it's only spikes or epileptic event that we can identify on EEG, but the patient is not aware of that. Some patients have a lot of interictal activity and not that many seizures. So there were a few studies that were interested in can we localize the epileptogenic zone using the interictal epileptiform discharges? Because if we have a patient coming in the lab and even if it's seizure-free, some of them will not have seizures during the recording, because some patients have only a seizure once in a while, but they are frequent enough, and they can have very negative impact on their life. For example, they cannot drive or they cannot work in their field because they have refractory seizures that are refractory to medication. So it's still very important to localize. They can still be candidate for surgery. So we were wondering, can we localize the epileptogenic zone using only interictal activity? So it would be less time consuming and resource consuming when they come to the lab, and we would have more conclusive results. And this team from the Polytechnique in Montreal compared the data from fNIRS-EEG. So they marked all interictal activity on the EEG, and they look at the fNIRS, and they also did the same with EEG fMRI, and they showed that it's possible to localize epilepsy using interictal activity, which is a very good news. So we can use it also in clinic. And for a couple of years now, there are a few papers that have come out on the potential of using fNIRS-EEG to early detect or even predict seizures. So in this paper from Dr. Fabrice Valois' team in Amiens, in northern France, they use a rat model of epilepsy to record intracranial fNIRS-EEG. And so on this figure, we can see again time in seconds here. And they look at interictal spikes found on EEG. They average them, and they look at the fNIRS signal associated with the spikes. So all the spikes that were averaged start here at 0 here in seconds. But as you can see, several seconds before the occurrence of the interictal spike starting here, there are significant changes in the fNIRS hemodynamic response, suggesting that NIRs has the potential to detect imminent seizure. And more recently, the team, again at the Polytechnique Montreal, used the same objective, but in humans, and they use deep learning methods to investigate the benefits of integrating fNIRS measure for seizure detection. They found that EEG fNIRS has this multimodal technique has a sensitivity of 90%, almost 90%, and about 95% of specificity for seizure detection. And they conclude that EEG fNIRS has the potential for providing a non-invasively detected signal of an imminent seizure. So, of course, more research is needed to develop a better way to use this in clinic, but it could be used, for instance, to increase the ability to detect on real-time epileptogenic activity in a critically ill patient, for example, at the ICU, and it could be used to optimize their treatment or to provide treatment earlier. So now I'm going to switch gear a little and talk about how we can use fNIRS-EEG in the pre-surgical assessment to localize language areas. So as Alejandra told you before, there are several techniques that have been used. The gold standard to localize, to clearly and precisely localized language areas is intracranial investigation. So using electrodes and using cortical stimulation. But of course, it's very invasive. There have been also the VADA tests that has been used It's still used in some centers, not that much in North America. There are almost no center in North America that use it because we don't have access to the anesthetic product to perform this test. And this test is quite invasive, and in children, it's conclusive in only about 40% of children. So it's not very. It's a hard technique for children. It's not always conclusive. And the past maybe almost 20 years now, we have been working a lot on developing localization of language function in epileptic patients using neuroimaging, non-invasive methods like fMRI or MEG. And these techniques work very well in some children, but super well in adult patients. But all these techniques have some limitations. So some of them are invasive, some of them are expensive or not always accessible, like MEG is not accessible in many centers. And some of them, or all of them, are not always suitable for patients with major cognitive or behavioral deficits or with pediatric or with young children. So that's why we have been working on using fNIRS-EEG as an alternative for children and challenged patients. So I'm gonna present you a series of studies how we use the fNIRS-EEG or fNIRS to localize language in children and adults with epilepsy. In these studies, the patient or the participant perform a verbal fluency task to localize the expressive language areas, and they also perform passive story listening task to localize the receptive language areas into their brain. So these patients, they underwent fNIRS-EEG recordings over anterior and posterior language cerebral areas. So we can localize both like expressive and receptive language. And also we can look at brain reorganization into the brain. So why using simultaneous fNIRS-EEG? So Alejandra gave you some cues before, and I also did, but it's very, very important to combine the EEG to fNIRS to localize the language functions, because as I showed you, a seizure, epileptic seizure, is associated with hemodynamic changes in the fNIRS data that can mimic hemodynamic response to, for example, a language task. So it's very important while we are recording to identify on the EEG all epileptic activity, enterical and ictal activity. So all the fNIRS data segment contaminated with this activity that we capture on the EEG can be removed from the fNIRS data before doing the analysis. So this is another example I wanted to show you. It's a old one. This is the first one we did to localize receptive and expressive language. It was a 9-year-old boy with probable left temporal epileptic focus. His seizures started at age 5, and they were refractory to medication. This child had autism spectrum disorder, intellectual disability, and he also had severe anxiety issues. And related to his autism spectrum disorder, he had a very repetitive movement of the upper body like this. So he had a lot of movement during the recording. His medical team tried to do a VADA test and fMRI, but they were inconclusive due to the very poor collaboration of the patient, the repetitive movement. He was too anxious to stay in the fMRI or to do the VADA test. So he came with his family to the lab. They were from New York City, and they came to the lab to do a fNIRS recording to localize his language. And we cannot see all the results. It was just an overview, but these results indicate that he had a predominantly left-sided expressive language in Broca's areas, which is very typical as a result during a verbal fluency task. And but he also had an ipsilateral cortical recruitment, as you can see here, in more posterior regions, which is not very typical in this task. This activation that is simultaneous with the Broca's area. For the receptive task, so the passive story listening task, we had bilateral. It's not very clear on that picture, but there was a bilateral cerebral pattern that is perhaps probably an expression of cerebral plasticity or compensation in this young patient. So we realized with that patient that it was possible to do fNIRS-EEG to localize language in patient with very severe cognitive and behavior problems, and we can also identify reorganization or altered pattern of language networks. Yeah, so this is another case that showed the utility of fNIRS-EEG in epilepsy to localize language areas, but also to characterize cerebral reorganization after brain surgery. So this was a little boy with a neuroglial tumor in the left temporal lobe, including Wernicke's area. He had seizure onset at 5 years, and he underwent 2 resective surgeries, so one at 6 and one at 10 years old. He had 2 fNIRS-EEG and 2 fMRI pre-surgically, so before each of the surgery, to localize language. And this child had normal intellectual functioning, but he has some executive attention and language deficits. So first, these are the results for the expressive language of the verbal fluency task at 6 years old. At that age, we didn't perform the receptive language task. A matter of time. So these results show here that this is time again in seconds on the x-axis, and the 0 here show the start of the language task. And these are changes in OXC, the full line, and DOXC, the dotted line, during the language task. We have here in blue the result from the left hemisphere and in red from the right hemisphere. And these are the topographic views. So we can clearly see that there is left hemispheric dominance, as we can also see here, for the expressive language in this child. Unfortunately, at that age, the fMRI was inconclusive. He was only 6 years old, so it was really hard for him to stay alone in the scanner and to perform a task. But with the NIRs, the parents were there close to him, so it was easy for him to do it. So he had his first surgery, and the seizures decreased, but unfortunately, he still had refractory epilepsy after the first surgery. So the medical team decided to do another pre-surgical workup to see where are these seizures come from, and is it possible to do a second surgery, because we remember that at 6 years old the language was in the left hemisphere, so we didn't want to do another surgery and to have very severe language deficits afterwards. So at 10 years old, these are the results from the verbal fluency task with the fNIRS-EEG, and we were very surprised. That's a good example of brain plasticity, because here we can see that in red, we have the result, the fNIRS-EEG result, the fNIRS result from the right hemisphere, and in blue from the left hemisphere. And we can clearly see that the proeminent activation is in the right temporal lobe in this child. There is a smaller contralateral activation here, but still it's right hemispheric dominant at 10 years old. At that age, the child also underwent a fMRI, and these are the results, and it was complicated because the result from the fMRI showed left hemispheric dominance, very close from the past resective area for language, while he was performing a verbal fluency task into the scanner. So we were wondering what's going on, where does the expressive language in the right or in the frontal hemisphere now. So we looked more carefully to the fNIRS results at 10 years old in response to the expressive, like you can see here in the upper section, but also to the receptive language here. And we can clearly see that not only the expressive language, but the receptive language is clearly dominantly located in the right temporal area, which is different compared to the fMRI result I just showed you before. So this patient underwent surgery, and because we were thinking, if this patient didn't have the EEG combined with fMRI when they did the fMRI acquisition, so our hypothesis was that the language, that the results here, that what we are identifying as the language area is actually the seizure or the epileptogenic zone, because his EEG was so active that it was not possible to remove the epileptogenic activity from the fMRI data. So we were thinking we're just mapping epilepsy here. So he underwent the second surgery to resect a larger part of the temporal lobe, and he had stable language functions. He was also doing great epilepsy-wise, so he didn't have surgery for a while. I don't know now, but for a while after his surgery. So and he also had a post-surgical fMRI showing right hemispheric language dominance, as we had with fMRI, with fNIRs before the resection. So this confirmed the hypothesis that here what we see is the epileptic activity. So this shows how crucial is multimodal neuroimaging. So the importance of acquiring EEG simultaneously with fNIRs or with fMRI or with another technique in patients with epilepsy. So we don't, the data don't mislead us and identify epilepsy instead of another function we want to map. So back to this series of studies, all these studies, in many of them we had comparison of fNIRs result with other techniques, either fMRI, the VADA test, or the intracranial recordings, and we had a very good concordance between all these techniques. We also had conclusive results in patients who could not undergo the procedure, like this little boy from New York who was moving a lot during the recording. So, of course, I'm not saying that fNIRS-EEG is the only technique to localize the epileptogenic zone or language function, but I seriously think that it can contribute to the pre-surgical assessment in some patients, more specifically with young patient or patient with severe difficulties. So for several years now, fNIRS-EEG is part of the clinical workup in patient with refractory epilepsy or candidate to a surgery. So patients from our hospital and other hospitals in Montreal come to the lab to have this included in their pre-surgical workup. So I'll now turn it back to Alejandra.
Thank you very much. So as Anna has shown you, that the fNIRS-EEG assessment is now an integrative part of the pre-surgical workflow in epilepsy patients at the Saint-Justine Hospital in Montreal. But she also emphasized that it can sometimes be challenging to obtain reliable results in younger children or in patients who have comorbidities and cooperation may be limited. And so sometimes it's not possible to get reliable results or even to complete the tasks. And therefore, the resting state signal has an important value for this group of patients. And some years ago, a study in our lab was interested to see whether it would be possible to identify language or to do language localization based on the resting state signal. And for that, 25 healthy children between the age of 3 and 18 years old and 8 young adults were recruited and underwent simultaneous fNIRS-EEG recording at rest as well as during a expressive language task. Language networks were specified using a seed-based approach. You have to just go back on, please. So they were, the seed-based approach was used to identify language networks, and the regions of interest was the Broca's area. And the goal was to see whether the spatial distribution of networks identified in both settings would agree. So if it would lead to similar results. So what you can see on the left here is just a schematic view of the installation of the NIRs and EEG to cover the regions of interest, and an example of how it looks like when the cap is installed on the patient's head. And on the right, it's the average results for the language networks that have been identified for the resting state signal and based on the language task paradigm. On the next slide, I'm going to show you some examples of individuals of different age groups, and to show you how the language networks that were identified overlap between the resting state signal, the fNIRs, and the task-based signal. You can see this for the left hemisphere and for the right hemisphere. So first for a 3-year-old, 10-year-old, an 11-year-old, and a 30-year-old participant. And a DICE index was used to evaluate whether the networks would spatially overlap between both settings. And what was found is that actually in most patients, the DICE index was satisfyingly high, so suggesting a satisfying spatial overlap between networks, and that actually the networks, that we achieved the same or similar results in both settings. Another index that was used to compare how well both networks would, or both localization approaches would overlap, is the laterality index, which indicates in which hemisphere the network is predominant. So again, we saw a significant agreement between both techniques in for the resting state and the task-based signal for the networks, the language networks. So overall, these results are very promising and suggest that actually resting state signal can be used to identify language networks in healthy controls. But as the ultimate goal would be to apply the same approach in epilepsy patients, we conducted some exploratory analysis in a resting state data set of 8 epilepsy patients that were seen in our lab in the context of their pre-surgical workflow. In this case, it was signal decomposition that was used to identify language networks, because a seed-based approach would not have been reliable, since Anne showed you that the language localization is often altered in epilepsy patients, so we would not have known if the Broca's area is actually the core of the networks. And again, we looked at the DICE index and the laterality index to evaluate how well networks overlap or agree in both settings. And even though it was just 8 patients, that so it was really a low sample size, but even in these 8 patients, we saw that actually the networks identified in both settings show a satisfying overlap. This is unpublished work. As I said, it's very explanatory, but it shows that it may also be possible to use a resting state signal to identify language or to localize language functions in epilepsy patients. So now you have seen that the localization of language networks has an important value for the pre-surgical workflow in epilepsy patients, but you have also seen that it can sometimes be challenging to identify language localization, because these patients often show altered representation of language functions. So for example, they have a right hemispheric dominance, or even some patients show that some regions of the left hemisphere that are usually not associated with language functions are implicated in language processing. And in order to better understand how these alterations of language networks are, or to better understand how these patterns, or to better understand the patterns of reorganization of language networks in epilepsy patients, we initiated a study with children suffering from temporal or frontal lobe epilepsy. And we chose these 2 types of epilepsy because they represent the most common forms of epilepsy, but also because they affect several regions that are often associated, or usually associated, with language functions. So the objective of this study is to investigate how focal epilepsy alters cerebral organization of language networks, to identify, please go forward on, to identify how these network alterations are related to the cognitive functioning and which impact clinical factors such as age of seizure onset or seizure control may have on this association. So I'll show you now how exactly we acquire data for this project. So we use a NIRsCAD and OctiJump device to simultaneously assess cerebral activation. And as I said before, the multimodal fNIRS-EEG acquisition in epilepsy patients has several advantages. But for this study, the main reason to choose a multimodal paradigm was to be able to control for the impact of epileptic activity, and also to potentially apply multimodal functional connectivity analysis, which would allow to better understand network reorganization. As you can see on the lower part of the slide, optodes and electrodes are arranged so that we cover our regions of interest in the frontal and temporal area. The installation also includes 8 short distance channels. The EEG system comprises 21 channels, including 4 auxiliary channels that measure the cardiac and muscular activation, the respiration, and the oxygen, the peripheral oxygen saturation. The cerebral activation in this study is assessed during a 12 minutes resting state period and also during expressive as well as receptive language tasks. Both of these task paradigms are administered in a block design. So this is to give you some details about the acquisition itself. So the fNIRS data says that the sampling rate is 7.8 Hz with a bilateral installation. And it's mainly based on the NIRStar and the brain vision recorder softwares that allow us to visualize and calibrate the signal prior to the recording, but also to monitor signal quality throughout the entire acquisition. We use presentation software to initiate the paradigms, and this allows us to send triggers from the stimuli to both the NIRS and the EEG device, which allows us afterwards to have to be able to synchronize both signals during pre-processing. So now I will briefly present you some preliminary findings of this study. Results here are shown for 26 healthy controls and 15 epilepsy patients. We compared first social affective functioning and the results of a short neuropsychological assessment between healthy controls and epilepsy patients. And what you can see here is that so far, both groups achieve results or a performance that lies within the normative range, which is indicated with the orange rectangle. However, when we look at group comparisons between epilepsy patients and healthy controls, we see that in all cognitive domains, epilepsy patients have significantly lower performance compared to their healthy peers. So to the next slide. So the focus of the preliminary analysis of the fNIRS and EEG signal lies on the resting state signal. So the analysis includes the exclusion of noisy intervals and segments where we have identified epileptic activity. This was done based on the EEG signal by an pediatric epileptologist. And so we could exclude all the periods that would potentially be contaminated by epileptic activity. And once the light was transformed into concentration changes of HBO and HPR, we used a phase coherence in low frequency bands as a measure of functional connectivity and applied 2 sample t-tests to the connectivity matrices to compare healthy controls to several subgroups of epilepsy patients. So, so far, this preliminary analysis allowed us to identify several differences between healthy controls and patients with left or right lateralized epilepsy, and between healthy controls and children with temporal or frontal lobe epilepsy, which you can see in the following connectograms. In these connectograms, all the significant differences between healthy controls and left or right epilepsy patients are illustrated. So these are all significant differences. And in the next 4 connectograms, you see the same for healthy controls compared to temporal and frontal lobe epilepsy. I'm not going into the details of specific patterns of alterations, because as I said, these are preliminary results. what we can say today that there are alterations of functional brain networks in children with temporal and frontal lobe epilepsies, and that their cognitive performance is actually significantly lower compared to their healthy peers. So in the future, more robust analysis and more sophisticated analysis will allow to interpret detailed patterns of cerebral reorganization, to assess also the association that these cerebral organizations have with the cognitive functioning, and to see how potentially clinical factors may alter this association. The goal of this study ultimately is to contribute to a better understanding of patterns of cerebral reorganization related to focal epilepsy, to understand how, to understand their functional impact, and ultimately this will allow to install early intervention for children that actually are in need of support. So now I have the pleasure to give the word to Phetsamone, who will present you the technical and practical aspects of fNIRS-EEG in epilepsy patients.
Okay, can you see my slides?
Yeah.
Okay, let's start. Thank you so much for being here with us today. Thank you for the great presentation. Now, as you know, advances in NIRs-EEG technology allow us to acquire data much easier than before. But to have a successful evaluation in children, it is still essential to adapt our way of doing things. For my part of the presentation, I will share with you my tip and trick in the technical and practical aspect of NIRs and EEG in epilepsy assessment. So first, to avoid an unknown and stressful situation, we do communicate or detail protocol procedure how NIRs and EEG assessment will be done before they visit by email or by phone. We also refer to them our website with the technical aspect of NIRs-EEG and a picture of a child with the cap on. Then questions about the epileptic episodes and participants' behaviors are asked, so the protocol can be adapted to the age and cognitive level. For instance, in the receptive language, instead of listening to a pre-recorded story, the parent can read the child's favorite book by referring to the marker on the monitor. As for the expressive language, the children's favorite theme is used as stimuli. Also, with the help of the parents, the child can practice naming the words belonging to each stimulus category at home. And to minimize the participants' time in the lab, the proper size cap is prepared before the testing day. With the head circumference measured by the parents, the parent can refer to the attached measurement protocol sent earlier by email. And for EEG signal quality, we always ask the parent to wash the child's hair a day before the testing. And of course, for his and her comfort, they can bring their favorite movie, snack, and comfort blanket or toys to use during the installation. And here, this is the LIONlab configuration for our NIRs and EEG system. So as Alejandra already mentioned, that we use the NIRS Scout with 16 sources and 24 detectors. And we do have the ActiChamp 64 channels with 8 possible auxiliary inputs. We also use the infrared camera to record in the dim room, as we found that the children to be more relaxed in this environment. And for epilepsy studies, we use all the source and detectors and 8 short distance channels. And for the EEG, we use the 1020 system, which include 21 electrodes. And furthermore, we add auxiliary input, as mentioned, as Alejandra mentioned, which is the EKG, EOT, and respiratory, and also the sensor, pulse sensors. And all of the experiments is performed using presentation software. And you can see on the picture on the right side, all systems are in one card, which allow us to acquire data outside the lab. We can, for example, acquire data in the NICU or in the patient's room. As for the material, we always prepare it in advance. So we do, let me show you the cap. So the proper cap size with the montage, including the electrodes, optodes, and short distance. And as I mentioned, we have also the auxiliary input. And as for the material, we prepare this wrench with the electrode gel, alcohol swab, new prep, marker pen, measuring tape, chest and breathing belts. And finally, we use the LED rechargeable light stick over here. I don't know if I can switch. Oh. Yeah, but we use the LED light stick to remove the hair under the optodes. Next to the picture. So this picture shows the short distance channels in the inside of the cap. For the good installation, it is essential to attach the wires between the optodes or the electrodes. This prevents the wires from being under the optodes and electrode during the installation. And I don't think that you can see my my mouse, but in the picture you can see around the ears that we added the elastic above the ears to tighten the optodes around the ears to have a better signal quality. And we also sew the washers to prevent them from coming off when we install the optodes with the spring grommets. You will see for the next one what is exactly I mean by spring grommets. Okay. And here is the standard connector that we use in the forehead, which is the area that it's more sensitive. And here is the spring grommet in my hands. And we have two types of spring grommets. The green one, which is used in sensitive area because they put less tension on the skin. Whereas the one with numbers are used in area with more hairs where the pressure is needed for better contact. So each sensor and detectors are identified by their number. Sensors are coded in red and detector in blue. So it allows us to be fast in our installation, and with that, it seems that our mistakes putting the wrong optodes in the area, it's diminished with this procedure. And for the good skin contact for both NIRs and EEG, we make sure that the wires aren't too stretched or pulling. So with this approach, it did allow us to complete our assessment without compromising the comfort of the participant. And here's the video of the testing day. So as soon as the participants and his parents arrive, the installation step and protocol are explained to reassure them. And of course, we don't forget to disinfect our hands because we don't want it to have any germs in our lab. So after obtaining signed consent, the cap is presented to them with a child-adapted explanation. So I start by explaining the EEG as a drawing of the brain signal. When he's calm, the drawing is beautiful. And when he moves, the drawing is scribbled. And for the NIRs principle, I show the flashlight through his fingernails. And later on, you will see that I always show the truncated needle to make him understand that there's nothing's freaking or painful during the installation. So I also explained to him that while he watched the movie, we will put the cap on him and he will feel a bit of pressure from the optodes, but it doesn't hurt. I have to make sure that he understands that the cap is fragile. He doesn't need to touch it or pull it. He should let us know when something is bothering him so we can adjust it. After finishing the installation, I will explain the game and the time that each of the game will last. And at the end, of course, to prompt his motivation, I always mention that he will win a game, a surprise at the end of the game. And for the installation, I start by measuring the 10% from the Malaysian Union to have a standardized localization each time we put the cap on. So after that, I cleanse the scalp with alcohol and new prep for EEG area, finishing with the key 2 EEG electrodes on the chest. And for the cap placement, I make sure to put the FPZ of the cap on the marked Malaysian Union 10%. Then with the child's help, to hold on to the cap, we can adjust and center the cap. Then after that, attach the chin and the chest strap, sorry. And then I make sure that the ears are through the cap ear holes. While my colleague use the LED light stick to remove the hair on the diopters, I usually add 3 phones, 1 in the frontal area and 2 on each frontal temporal area for more comfort. And then EOG electrodes is placed to record eye movement. And we usually tape the wires on the participant's shoulder to prevent them from coming off again during the child's movement. And then we put on the breathing sensors on the tummy. And the pulse sensor can be placed on the fingernail. And on the picture, you can see that we are using a newborn's sensor because they are more comfortable compared to the adult one and much smaller also. And make sure to tape it well. And we have another tape to cover the light so they don't see it too much, so they don't tend to go and touch it and move it. And here, I usually prefer to clean the electrodes with the Q-tips with the new prep in the frontal area because it's much less abrasive than the truncated needle, like I mentioned before. And finally, I use the conductive gel for each of the electrodes. And you can see that first, I do move a bit of hair and add a bit of gel. You don't need to have too much of gel. So I also don't insist by having the good impedance at once. I just go forward to the next electrodes. The gel will settle and the impedance will reduce by itself. So it makes it more comfortable for the child. Okay, let's go to the next one. So for the recording, we always validate the comfort of the participant before the testing and the end of the task also. So when he's comfortable, everything's good, and we can start doing the NIRs calibration and the impedance measure. Let me stop it here. When the quality signal are achieved, we put on the overcap to limit the light from the infrared camera. So in this picture, you can see that the cap is put backward because we only need to protect the optodes from the light, hence why it is unzipped. And I find it's the backward, it's larger than the front. So that's why I have been inversing it. So I want to make sure that the NIRx people don't knows about that. So yeah, and everything's fine. Though we start doing the NIRs and EEG recording, and we start presenting the presentation. My colleague is noting the start time and the end time on the spreadsheets, and the artifacts timing is also marked to make sure that to know when exactly what is happening. At the end of the testing, we always take a photo to have the cap positions, and we also we can digitalize the electrodes and octodes coordinates, but it's done on the next adjacent room. This is it. It's not too complicated. So after we have acquired very beautiful data, what do we do with it? So we have NIRs-EEG data analyzed with our LIONirs or in-house software. The paper from Tremblay and al. LIONirs paper is still under revision, but today I will share with you an overview of some of its features for epilepsy analysis. The first feature is the read and synchronize the NIRs-EEG data and the video using the stimulus marker. This makes it possible to associate artifacts and epileptic waveform in both the NIRs and EEG to the behavioral. So the second model is more the artifact detection mentioned earlier by Alejandra. So it uses the FFT and channels coherence measurement. So these models allows bad channels to be excluded and also provide a list of rejected channels. So this kind of make our life much easier. So we don't need to go through each channel and have it selected by hand. So let me show the example of the figure, what exactly it does. So in figure A and C, you can see that the power spectrum of all channels. And you can see that we can locate the heartbeat easily when the channel is good. And in the middle one is the raw data. So it shows the bad channels in red and a good channel within EKG signal in blue. The third model is more the artifact detection. So it uses different rejection methods. So I will mention 4 of them. If you want to have more detail about our toolbox, you can maybe later on, when it's published, you can have a publication. And also we have a website. You can feel free to ask. And I am pretty sure that we'll try our best to answer your questions. Like the first one is the moving average to detect sudden change in the data. The second rejection of the channels or segment with less than 50% of good signal. And the third one, identify the artifact within the minimum software interval. So every mark period within the same time is considered as one artifact. So the last one, identify similarity between channels that have the same artifact configuration. So again, it allows us to clean it much easier and faster. So the LIONirs allowed to correct the artifact to avoid losing too much data, especially in children. So PCA, ICA, parafact, GLM can be used to identify the artifact signature, then subtract them from the data. And the topographic representations allow to identify the origin of the artifact. In this module, we can also apply the physiology regression with the short distance channels as described in Saga and Berger 2008. And we can also use the GLM regression for the short channels with its neighboring area or by the mean average of all short distance channels. But in case that you don't have the short distance, you can also apply the GLM regression on overall channel mean average. So the last step, it's the standard step, such as normalization, that is applied between the pre-time and post-time of each stimulus. We can apply the low-pass filter to remove high-frequency signal and have our wavelength modified with Beer-Lambert law. And we can also epoch averaging each of the stimulus condition. And the t-test and commutation against the baseline or stimulus condition, or even from a group, can be also applied. So topographic representation is also used to identify the activation related to cognitive function or the epileptic focus. This video shows a topographic representation of the t-value during the period of hemodynamic response during language assessments. The montage can be projected onto the participant MRI, or we can also use the template from the MNI Institute in Montreal. And here, this is a result of a left-handed 70-year-old girl who has a lesional epileptic origin in the left temporal lobe. So the change, sorry. Yeah, let me show it again. So the changes in HVO started on the right frontal area, showing the right hemispheric dominance for expressive language processing. So with all result and other neuroimaging results, the region has been removed without affecting the language function. So now it's a second case. So as part of the assessment for epileptic surgery, the 4-year-old girl was referred for fNIRS-EEG language localization. She presented a non-regional epileptic in the left temporal lobe with a barely developed expressive language. Her seizures started when she was only 2 years old. In that time, no brain imaging was possible due to her lack of cooperation. Fortunately, we were able to assess the function of the receptive language with the story listening paradigm. During this task, she was listening to the story of her favorite book read by her mother. So as the result, and a typical receptive language pattern with the right hemispheric dominance and a higher HBO activation in the interior frontal compared to the posterior frontal region was found. So these results highlight the transfer of the receptive language to the right hemisphere, which is expected when the onset of epileptic seizure occurs at such a young age. From these results, surgery for the suspicious left temporal foci was removed, and since then her language function had continued to improve. Here I'm at the end of my presentation. Thank you for your attention and time. And special thanks to Henri, Cassandra, and Stéphane for making the video with us. And of course, thanks to our team and collaborators. Last but not least, thank you to all the participants who allows me to put on all sorts of headgear on them. Thank you.
Wonderful. Okay. Thanks a lot, Phetsamone. This was a lot of knowledge. I must admit, I haven't read much on epilepsy, and I was not even aware of how you would use fNIRs for that. And your presentation was wonderful, starting with Alejandra, you introduced us to how to use fNIRs and EEG for epilepsy. And Phetsamone, those really nice videos you showed, I think that gave the audience a really good idea of how the setup looks, what are the things you need to consider, right? And it's the data quality that matters at the end of the day, and you showed how how a really good cap looks like and what are the things you need to, comfort wise also how you take care of participants' comfort, which is so important in these sensitive participants, right? So thanks a lot for that. We do have some questions. And first of all, a lot of people like me are very thankful for your presentation, for your time. I think this was knowledgeable. Even two people say that they have never seen a presentation on fNIRS-EEG in epilepsy. So thanks for introducing us to that topic. Very nice. Okay, I will start with the questions. Right, there are some general ones we can take later. There's one that seems interesting. You talked about language area reorganization. Can the reorganization go beyond, for example, language areas? And part two of that question is, will a whole head functional connectivity provide more information on let's say the networks involved in a seizure, and yeah, what are your comments on that?
Yeah, that's a very good question. Actually, I would say yes to the question. First of all, we have been recording a lot of patients and looking at language reorganization for receptive expressive language, and most often we see reorganization within typical language area. However, it's not. We can also see recruitment of other areas. For example, the typical in 94% of the population, the language, the expressive language is left hemispheric dominant, and the Broca area is in the left hemisphere. But we can have the contralateral area, which is not typically associated to language that can be recruited, but still it's homologous. So this is the more frequent reorganization we'll see. So either the contralateral area that will be recruited, so like the right Broca's area, it doesn't exist, but the contralateral Broca's area, or either the reorganization recruiting more posterior areas are associated with more often receptive language. But we now know that it's not, language is not located in one area, or we know that network. So it's a lot of areas are included into the brain in both hemisphere, but more often we see a reorganization or alteration because we're not sure that it's real reorganization. We think that it helps because the child still speak, but still we see in the Alejandra's data, we saw that the language function are still lower than healthy peers. So we know it's probably reorganization, but a part of it is also alteration. So most of the reorganization or the alteration of the language networks are recruiting language area, but it's not always the case. So of course, the more we can record, the better it is. If we can do a full head, it's much better. There have been some studies doing that, and beautiful studies, and it's very rich. We can see we can investigate much more using more channels, but we have to be realistic because we're working with patients, we're working with children, so we want to balance how much time we want to pass on the installation and how much time it will last. Like the child will keep the hat on and will collaborate with some language tasks also. So we need to do a balance of that. So in some healthy studies, we will do as much as possible. We'll record a full head if possible, but in clinical studies, we'll try to find this balance, not to take too much time to install and to have more good quality data and more tasks.
And add to that the complexity of multimodal integration, right? So it's not only EEG or fNIRS, it's both of those techniques, and you have additional sensors as well. So being mindful of the comfort of the participants, yes.
Absolutely.
Okay. There's one more question, which is not very clear to me, but we can maybe try to figure this out together. What is your opinion on superficial physiology changes during a seizure? and how are they different from a normal participant, and how can we detect them?
This is another very good question. Maybe I can start, and Phetsamone and Alejandra, you can complete. I don't have the answer to that neither. I'm not sure we actually know the answer in the literature. There have been some studies looking at this, what it's the impact of seizure activity on the physiology, but I don't know very well that literature. So I think that anyway, the important thing is to be able to be aware to record and to be able to remove the physiological noise in these patients. So as Phetsamone showed in the videos, it's important to have short channels, or there have been also a lot of discussion about how to remove physiological noise, but at least we need to record it and to be aware and to be aware of it, to record it and to remove it in a good way. Maybe my colleagues want to add some information or are aware about other studies.
For the short channels is continuously recorded. So what is nice about our toolbox is when you segmented it, the area that you want to analyze, you also have the short channels when the seizure occurred during that period. So the short channels is already recorded, unless if it's bad, you cannot use it, or when it's good, you can still try to remove it and see what is the impact of the result is. So we are all new with the short channels. Everybody's trying all sorts of things, and we are among them. But I think it's the best way is to try and see what is happening. But for my thinking is when you have a seizure, it's so strong without the superficial or no, it doesn't matter much because you want to see what is happening in the brain. And it was shown it will you will be able to, with the topography, make the seizure, the lesion stand out from all of our recordings that we have.
Right, absolutely. And for the short channels, there seems to be a general consensus. I was looking at the standardization paper that came out a few weeks or months ago, and they also mentioned the need. Actually, I think they've used the word need of having a short channel set up in your measurements. Yeah. Okay.
But there was also this publication recently that emphasized it's not only the short distance, but it's like all these auxiliary channels. The more we have, the more we can include to in the estimation of the cerebral activation, the better we will understand, or we will disentangle the what is related to what. And like we're trying also things like with that. The challenge so far from my side is that many of these things work very well in task-based paradigms. It's a bit more challenging in resting state because we don't know what the exact hemodynamic, there's no the hemodynamic response that we can model. So it's very hard or harder to clearly correct for the impact of other physiology.
Yeah.
Back to the question, and an interesting way to look at it also would be to look at, since it's continuous, as Phetsamone said, the short channel, we could look at the differences between, for example, during electrical seizures, which are, let's choose it. So we can look at differences in short channels between and during electrical seizures in patients that we had several of them. It would be interesting. We didn't look at it yet. It's nice.
So the thing is, people are saying we should exclude, but what I think the most important for me is to understand what exactly all the physiology, auxiliary influences on the data, to have a study by itself on all of the things that we have been recorded to understand it and make sense if it's necessary to exclude it or not. I think we still have a long way to go with that.
Right. Okay. Few more questions. I'm mindful of your time, so some of the questions our team has already handled. Some of the questions we can take offline because they are very specific. There are some here. When you record EEG and fNIRs, how do you calculate the SNR for EEG and fNIRs? And this is a big topic. I know we don't need to go into detail, so if you could just briefly, I think that should be sufficient.
Well, for the EEG, the signal to noise quality, it's very obvious because when it had been done quite a while, you can see that if you don't filter the data, you can calculate it with the noise, the EEG without filtering, what is the ratio from cleaning for filtering. But for the NIRs itself, it's still a debate for myself because it's a new thing. We don't know exactly what exactly artifact movement look like. It depends on the subject, and it's still changed. So that's why I think having EEG and NIRs allowed us to understand better, because we do know what exactly artifact related to motion or eye blinking looks like in EEG, but still we don't exactly know how the NIRs look like. And from doing a lot of recording, I still, you know, having hard time to identify what exactly these artifacts from NIRs relate to. Sometimes I think, okay, I got it, it's related because the child is breathing too much, but then suddenly, oh, it disappeared and he's still breathing. So it's a lot of things to consider. So having the video itself, this is a new thing because we just bought the infrared camera, and it will be able to understand, to have the connection between everything that we had been recorded. So maybe in a few years, if we come back and with a new webinar, we'll be able to answer a clear answer with you guys.
Yeah, absolutely. And there's a question, but I think you already answered that. The question is related to, does the infrared camera impact the fNIRs? And you showed us the cap setup, and I think that's really the answer, right? The overcap is for the camera only.
Yeah. Yeah, before using it, you need to test everything. When you add on equipment, you have to make sure that it doesn't have any impact on your data. So for myself, I have been trying to record with the cap on, with no cap on, with infrared camera put on, without it. And I found the advantage to be able to see what is happening. It's much nicer than having nothing at all. I can tell you that if you don't put the overcap on, you can see that the signal from itself, it's higher. Like the noise, the object seems to acquire more light. But you know, if it's general, it affects. Of course, if you do, it depends on how you set the camera. If you set it on the side like we did, the impact would be more on the side of the camera. But then you have to make sure that you put on the overcap.
Right. Okay. Okay. There are lots of questions, and lots of people are still thanking you for the presentation. I think this was really good. If there are some questions, we can reach out to you. I think our support team can also handle them. And yeah, once again, this was fantastic. And for our users, we have recorded this webinar, so we will put this on our website. If you have any questions for our speakers, it's not very hard to find them by a Google search, but you can also reach out to us, and we can also then ask your questions from them. And once again, then, I'm Alejandra Phetsamone. Thank you so much.
Thank you.
Thank you very much. It was a great pleasure participating in your webinar series. Thanks a lot.
Thank you.
Thank you very much for the opportunity.
Questions.
Thank you.
Bye-bye.
Bye. Thank you.